All right, what's up? Happy Friday. We're in. All right, waving back at everybody. Hope everybody's doing well. Hope everybody's had a good week. I'm ready to answer your questions. So, again, this is kind of that open forum for those of you that have never been here before. Start asking away. So, we got any questions that you have, fitness, performance related, um, anything like that, feel free to write in the chat. Again, if you're having specific issues or specific pains or anything like that, I can't really help you on in this virtual format. Um, but I'll do the best I can. I can give you as good a direction as I can, and we'll kind of get going here. So I'm actually headed off to New York today for the corrective exercise course. We have one more virtual option for anybody who wants to do virtual corrective exercise course. That's November. And then we have a manual therapy course. And then we're pretty much done for the year. So we have our regular schedule back up for 2022. So hopefully I'll catch some of you guys there. But like I said, ask away. Fitness, performance, anything that you've seen, read about, heard about, anything like that that has come across your Instagram feed over the last week or so. I'm happy to answer. Hip dips. Hip dip. I don't know what you mean by a hip dip. Whether there's something that can be changed through training. If you're talking about kind of the shape of the hip, right? How that hip kind of has a different kind of shape to it. You're not going to be able to change the skeletal structure of somebody, regardless of the type of training that you do. So I don't know if you're talking about like the little kind of like call them dimples in the backside or just kind of the hip shape forward, backwards, left, right, whatever it kind of looks like. Um, you're not changing skeletal structure no matter how much corrective exercise or physical therapy or strength training you can do. What you can do, though, is obviously with a glute training approach, is obviously, I'm assuming that's kind of what you're dealing with. A glute training approach, you can maximize obviously hypertrophy of that musculature in and around the hip. So, again, one of those things where you get all the times like, I want to look like this person or that person. That might not be possible. We all have kind of a little different skeletal shape, height, width, all that stuff is different in people. So you may not look exactly like X, Y, and Z person, but what you can do is you work hard, you train, and you get what you get, and you emphasize what you have and what your potential is. So I'm not going to go kind of into the conversation with somebody like, "Hey, I'm going to get you to look exactly like I don't know, The Rock," right? Um, that's everybody's a little bit different on that side of things. I'm going to say, hey, let's put forth a great effort in our hypertrophy training or strength training or endurance training or whatever it is, and we're going to get as best we can, right? That's kind of my goal. That's kind of the conversations that I have. And I think comparison is the thief of joy. So don't try and compare yourself to everybody else. Well, which exercise for hamstring pain? None. None of the above. I know we get a lot of hamstring questions on here. There's a lot of hamstring stuff that's just out there. Number one, if you're having pain or discomfort, do an assessment, go see somebody, identify what the root cause is. That pain might be, some underlying something or other. So, number one, go get an assessment done, go see somebody, go whatever. Number two, the hamstrings tend to be this overactive synergist, this muscle that takes the kind of role of your primary hip extensor. So your glutes, when the glutes shut down, you have this synergist of the hamstring kind of ramp up its activity, and that creates all kinds of problems from increase in potential hamstring injuries, hamstring tears, or even hamstring pain. So what I would say for you is go see somebody, or do, and if it's not excruciatingly painful or really debilitating, do that overhead squat assessment and see what you find. See what sort of movement compensations you have, and then go back to the drawing board of, okay, what muscles would be overactive, what muscles would be underactive, what muscles would be lengthened, what muscles would be shortened, and kind of address it as such. More than likely, what you'll find, I'm assuming, and again, I don't know you and I don't know what the issues are, but more than likely, you're probably going to find some lumbopelvic hip complex dysfunction and maybe even some lower extremity dysfunction. And if you address that and you focus on that stuff, I can probably assure you that your outcomes are going to be better than just throwing an arbitrary hamstring exercise at you, right? So hopefully that's a little helpful, and hopefully that kind of sets you off in the right direction. Waving back at everybody that waved at me, everybody that's waving at me, asked me stuff. Um, Neck exercises. So some neck exercises. In the corrective exercise realm, we have a lot of this forward head position that we see with clients and patients, depending on what your profession is. So we have to start thinking about, okay, if I have that forward head position, right, what are some of the overactive and underactive muscles? And I actually did a webinar on this not too long ago, maybe a month or two ago, on that cervical dysfunction. I would suggest going back, taking a look at some of those courses that deal with cervical dysfunction. But really, what we can start to think about is we need to get some of the overactive tissues to turn down. And oddly enough, a lot of them end up being some of the scapular muscles as well. So, levator, potential upper traps, things like that. Obviously, if you're SCM and you have your scalenes, and those sometimes take a little bit more manual therapy to deal with. But then we also have that longus coli, longus capitis, which ends up being a underactive muscle for that head forward position, or just kind of an underactive muscle in general. So I would say, number one, go back, check out some of those courses on cervical dysfunction. And number two, implement a little bit of that scapular release of levator, upper trap. Also incorporate some thoracic mobility in there because that actually also contributes to some cervical dysfunction as well. And then do some activations of those chin tucks. I think those are really, really good exercises that you can kind of integrate or sprinkle into somebody's somebody's routine, right? Especially if they're dealing with uh, neck discomfort. So hopefully that's helpful. I know it's kind of a broad answer. Now, obviously, if you're in the performance side of things, there are pieces of equipment that some football players may use called the iron neck, and it's just kind of a loaded movement. You have to determine whether that's appropriate for the clientele or patient population that you're working with, or the athletic population that you're working with. Crunches, sit-ups for someone with that crunches, sit-ups for someone with diastases recti. No, none of the above. I would stick to more of your anti-rotation pieces, your chop, your static chop progression. So you're not rotating those chops, more of a static chop progression. Things like that. Even your hip bridges and kind of stay along those lines. Maybe side planks, depending, and all those different plank variations might be okay if you can prop them up a little bit. Maybe not on the floor, right? So again, it'll depend on how bad that diastasis recti is, but I would probably stay away from the crunches and the sit-ups and really the core work for the most part, or the core emphasis for the most part, and start integrating some of the stability pieces, the TVA activation, your quadruped progressions, your hip bridge progressions, your like I said, your chop progressions, your static chop progressions, um, and things like that, right? And really, I've taken a little bit of the focus away, even for my general pop, um, taken away some of the crunches and definitely taken away the sit-ups, and really focused on more so of that TVA quadruped kind of variations, the hip bridge variation, the side plank variations, the chop variations. That kind of constitutes most of my abdominal core, quote unquote, core work. I've gone away from crunches and sit ups and things like that. Definitely don't do leg raises and all that wacky stuff. So hopefully that's helpful. Like I said, I'm not a huge, especially with somebody who's got diastasis recti, or whatever it might be. I tend to stay away from that crunch and sit up stuff. Good question. Um, Foam rolling. So Adonis, welcome back. Happy Friday. Thank you, as always, for your good questions. Foam rolling, actively rolling back and forth, is that any good for fascia, or we should only do static releases? So, great question. Um, when you roll up and down on that muscle, you actually kind of do the opposite of what you're attempting to do. So you tend to trigger a little bit of a mechanoreceptor response where you're making that muscle kind of, I don't know, fire back on, which is kind of the opposite of what we want to do with foam rolling. You have to think about foam rolling as, or foam roll as, a noun versus a verb, right? So that foam roll should be static. That's going to have the best release of that muscle or that overactive muscle. As you go up and down, actively rolling up and down, like I said, you tend to fire that muscle back up. So we don't want to do that with an overactive muscle. So you can do it static, right? So you can do the static release where you just kind of put pressure on whatever that muscle is, right? So you can put pressure on it and just kind of sit there. But then there's also that dynamic, or that pin and stretch technique, where you find that tender spot, you move slightly distally away from that tender spot or that trigger point, and then you use that joint motion, whatever joint you're looking at. Let's say this is the ankle, right? So you use that joint motion to pull that adhesion through that kind of blocking of the foam roller or the ball or whatever you're using. That's perfectly fine. That's okay. And I would suggest that versus the foam rolling straight up, straight down kind of thing. I know you see it all the time. I know a lot of people do it, um, but I think that does more harm than good. Patrick uh, from YouTube. Sorry, I couldn't see your question there. Again, another foam rolling question: should the muscle be in a stretch, shortened, or neutral, relaxed position? So again, depends on what type of um, rolling or soft tissue work you're going to do. If it's the static, you want that muscle kind of relaxed, or as relaxed or neutral as possible, right? Especially if you're, depending on how you're getting into that position. Now, if you're doing that pin and stretch technique, you're going to be putting pressure on that, and then you're going to be, moving that joint. So you're going to be actively lengthening and somewhat shortening that tissue that you're releasing. So it really just depends on what you're doing. But if you're doing a static release, try and keep it as neutral, off tension as much as possible. We do end up with something called muscle guarding. So if you are kind of in a tricky position, they'll kind of tense up, and that'll defeat the purpose as well. So you want to get them as comfortable and as neutral as possible for the static release. But like I said, if you're doing that dynamic or pin and stretch technique, you're going to go through a little bit more of a range of motion for that tissue, and that'll just help kind of create a little bit of that extensibility there in that tissue. Cool. Good questions, guys. Good. Cool. Let's see what else I got here. So, um, foam rollers for back and legs, are they bad? I hear bad things about them. So, foam rollers for legs are perfectly fine. I'm all right with that. I actually tend to like a foam roller better for lower body. So the calf release, the quad release, the TFL release. I tend to like a foam roller just because the balls, the trigger point balls, or if you're, whatever you're using, tend to kind of roll off to the side a little bit. So I like to use the foam rollers for lower body. I like the ball for upper body because it's easy to kind of put up against the wall. You can hit your levator, you can hit your rhomboids and upper traps with it, and then you can hit lats with it on the ground. But like I said, I like the foam roller for the legs and the ball for the upper body. Now for the back, we don't teach a lot of the release for the back. I know you might see like the peanut kind of thing. Okay, just be careful with that, right? Obviously, putting too much pressure is not a good thing. If you're using two giant, softballs, and you're going to lay somebody on there and press on them, that might be a little too aggressive. So I would kind of just be cautious about that. Again, if that's comfortable for you to use, maybe up against the wall, that might be okay. The soft tissue guns, or the Theraguns, or hyper that we use, the Hypervolts, they're all right. Like, you can use some of those for the back and the lats and hit all that stuff. If you're doing that, that's fine. So it's one of those things where, foam rolling's kind of interesting. Is that there's the right way to do it, right? And then there's ways to do it, and it's really not going to cause any major issues, right? Unless you're putting like way too much pressure and you're causing bruising and all that. It's one of those things that's like, I'd rather you just do it, right? Whether it's done poorly or done really well. It's one of those easy things that you can give people to do at home. And like, listen, if you're not doing it perfectly, you're still going to get a little bit of benefit out of it. So, if you give the calf foam roll to a client for them to do at home, and they just sit there and kind of roll up and down on it, right? It's not the worst thing in the world that they could be doing. So, just be careful. All in all, just be careful with it. Too much is certainly a bad thing. Spending more than 2 minutes probably isn't great for you. There's this diminishing return that you get. So hopefully 2 minutes on each side, and you're good, right? 2 minutes max on each side, and you're good. Cool, good questions. Does the IATSM tool, so instrument assisted, that's IASTM, but whatever, instrument assisted soft tissue tool and course included in the membership? Um, so the courses that we have are simply there for the education purpose. We do not give or provide or sell tools. You'd have to get them kind of on your own. So those courses, though, are there for the manual therapists out there. So that's available to anybody who does manual therapy work on their clients or does that IASTM on their clients. It's Physio DZ. The membership has all kinds of videos. It has articles. It has tests. It has everything that you could possibly want on all of that stuff. So it has the myofascial stuff. It actually Brent has a webinar that he did on the percussion, the hypervolt, and all those tools that are on there. So the vibration tools, the effects of that, that's all on there. Video format, course format, easy to read, text boxes on your phone on the app. So it is all up there for you. All you gotta do is join. Right? It's easy. Let's see. Good question here. Let's see. B yoga therapy. I'm sorry if I messed you up. Knee valgus. So your knees bow in and your right foot turns out. Which to address first? Great question. This is a very common sign. I think we all see that knee valgus, that knee bow in sign. And then sometimes that foot's going to turn out with it. And that's actually because knee valgus or knee bow in is a combination of femoral internal rotation and tibial external rotation or relative tibial external rotation. That's what creates that little bit of foot turnout. Now, one side could potentially turn out more than the other. What you have to do for the knee valgus is identify where it's coming from, number one. So you have to go, okay, I saw that in my overhead squat. Let me elevate my heels, squat again, right? And see if that knee valgus is still there. If it's still there, you get a little conundrum here. You have your right foot turnout, which is lower extremity dysfunction. And if your knees still bow in with heels elevated, then that's lumbopelvic hip complex dysfunction. So then we have to go to a hierarchy. Okay, do they have any obstructive dysfunctions, right? Hip pain, back pain, knee pain, whatever, right? And if they don't, then we go, okay, well, we had no obstructive dysfunctions. We have lumbopelvic hip complex dysfunction, and we have lower extremity dysfunction. And if just my right foot turned out and the other foot didn't, I have an asymmetry there. And in our hierarchy of treatment, it goes treat any obstructive dysfunction, or I should say, address any obstructive dysfunction first, then address any asymmetries. So to answer your question, if their heels elevated, their knee bow in was still there, I'm going to not worry about the knee bow in, and I'm going to address that right foot turnout. Right, so we have to go to the muscles of right foot turnout and what they are, and what contributes to that. It's your tibial external rotators like your bicep fem, your TFL, and your lateral gastroc. So I'm going to release them, potentially stretch some of them, mobilize that knee joint, and then do some activation of my tibial internal rotators, right? And then reassess and see how I did. However, okay, let's test the other way. If you elevate the heel and the knee bow out goes away, then I know it's lower extremity dysfunction. And I know, okay, cool, I'm still going to address the asymmetry. So I'm still addressing that right foot turnout. That's going to be the most important sign there. Depending on if they have any or if they don't have any obstructive dysfunctions. So a little bit more to it. I know it's a little tricky. Typically, you address any sort of asymmetries first, unless they have some sort of obstructive back pain, back pain, hip pain, something like that. Then I would address lumbopelvic hip. But and again, I'm not addressing the pain. I'm just going to address that segment. So lumbopelvic hip, upper body, whatever it might be. Posterior shoulder. So if somebody shoulder impingement, certainly can catch it early. What you can do is incorporate some of that upper body dysfunction corrective exercise. So release those common overactive muscles of lats and um, potentially posterior delt as an overactive synergist. Take care of some of that scapular muscles like levator, pec minor, rhomboids, all that fun stuff. I probably would kind of stay away from some of the joint mobilizations there, at least initially, and then maybe incorporate some of that corrective exercise for those external rotators, that infraspinatus, teres minor, low trap, mid trap stuff, and then kind of see how they progress. Now, obviously, if it's significantly painful or significantly causing significant discomfort, they certainly need to go see somebody. But if it's one of those things that's kind of like a nagging injury or a nagging issue, then maybe you can get in there as that in that early phase and kind of go from there. But again, if it's something that's significant, they had a significant injury. You said they're a wrestler, so if this was a significant injury during that sport, then they should certainly go see somebody first before you start messing around there. So like I said, the asymmetries we would address first. Glad I'm helpful, Donis. Good to see you. Happy Friday. Cool. Scrolling down. See what else. All right. So somebody who's got restriction of tibial internal rotation. This foot externally rotates or spins out. So yeah, strengthen the internal rotators of the hips. I probably wouldn't do that, right? So I probably wouldn't. And again, I don't know this client or I don't know this patient of yours, and I haven't done an assessment on them. But the internal rotators tend to be overactive. I probably wouldn't do much of that. Might want to try that knee mobilization as long as they're not hypermobile. You might want to try treating the tibial internal rotators, not the femoral internal rotators. So activation of tibial internal rotators to help prevent that foot turnout. But again, you know that client or patient best. You've done your assessment on them, so you have to kind of uh, make that program yourself. So that's the best of use the best of your abilities and your skill set. I would say go check out some of the courses on foot turnout, and that overhead squat, and see if that kind of helps lead you down the right way, right? On YouTube, I'm glad you enjoy our stuff, and I'm glad it's educational for you. No problem. um, Managing acute SI sprains, um, corrective exercise. It's easy. Assess, identify those dysfunctions, because everybody has something, right? So that's the idea, is to find the mm, quote unquote weak points in the chain, right? And address that. And that corrective exercise is just a quick 15-minute thing that you can do prior to doing whatever it is they're going to do. Do that assessment, identify what you see, treat what you see, and go from there. Low back pain can come from a lot of things. Yes, anterior pelvic tilt can potentially cause that. Underactive glutes can cause that. Um, Favoring one leg can cause that. That asymmetrical weight shift can cause that. So there's a lot of factors that can go in with back pain. That's why we don't use back pain. We don't treat back pain or knee pain or shoulder pain or neck pain. We have to treat dysfunction, not the diagnosis, right? So even though your client or patient will come to you say, "Hey, I have knee pain or back pain," don't internalize that. Go, okay, there's something there that's causing that, but don't just go, oh, okay, let's roll your back, or let's do this X, Y, and Z exercise that I saw. Make sure that you're doing your assessment and you're evaluating that assessment and breaking down the overactive muscles, the underactive muscles, what really needs to be worked on, and go from there. I would suggest if they are favoring that one leg, take that overhead squat, view them doing that from the posterior side, see if there's an asymmetrical shift. That may give you a little bit of that may give you a little bit better direction. And if you're not familiar with the asymmetrical weight shift or how to break it down, there's a video on the website for you on that one. Um, Dysfunctions certainly could be permanent, right? So if you have somebody, let's say, with scoliosis or something like that, like they're always going to have that asymmetrical weight shift. They may always have some discomfort or whatever. But if you're just dealing with somebody who's got like just knee bow in from underactive muscles or overactive muscles, they are certainly correctable, right? So that is a real thing, right? That corrective exercise is certainly a real thing. But if they, like I said, if they have that structural scoliosis, or if they, have some surgery, or they have a, joint replacement or something like that, you're never going to perfectly align them again. Um, but you still incorporate the corrective exercise approach, and it'll get them feeling better while they're training or while they're doing whatever it is that they're doing. So I would certainly say, don't give up on the corrective exercise. Make it more of a habit, make it more of their warm up on a regular basis. And I think they're going to feel a lot better. Hip impingement from heavy squats. Training forever, right? Or forevers. Hip impingement from heavy squats. Certainly, focus on some corrective exercise there. Those joint mobilizations might be very helpful. Again, do what you feel comfortable with that client or patient. Don't go too crazy there. Hi, everybody. Of course, you're welcome. Um, Best way to cure an anterior pelvic tilt, we are we throw that out there with the kind of lumbopelvic hip complex dysfunction component. Um, so that's kind of the best way that we could do that. So that lumbopelvic hip, there's some release of TFL, release rec fem, release maybe the anterior adductors, go into some hip mobilizations, potentially a thoracic and lumbosacral mobilization, and then activate glutes. That should be helpful for the anterior pelvic tilt. So there you go, Physiodz. The patient has a tibial fracture. Yes, so there you go. So there's some things there that obviously I did not know because you didn't tell me, and that's why I can't really tell you much on Instagram because I don't have that full perspective of that client or patient. So knowing that, and you have that information, you have that history, that's what you can do. Sure. See what else I got. Is it legit? Is the personal training cert from here legit? Sure. Why would it not be? It's 50 hours of coursework, just like any other certification that you would get. There's tests associated with each one, and we're cruising right along. We're actually in the process of getting these courses accredited, potentially for college credits. So yeah, we're pretty legit. There's a lot of good info out there. Not only are the courses online, you can also do Audible, so you can listen to the courses if you want to do that instead of reading. So we're up there. All right, happy Friday. That's it. My time's over. I apologize. I got to get off to work and then off to a flight to New York. So, guys, go have a great Friday. Enjoy the weekend. Go do great things. I always enjoy great questions. You guys are awesome. Um, Behave yourselves. If I missed your question, no worries. I'll be back on next week. Save those questions for next week. I'll see you then. Be good.